COVID. And our first speaker this afternoon, it's my pleasure to introduce Dr. Vicky Tagalakis. She's an associate professor of medicine at McGill University, and she is the chair and director of the General Internal Medicine Division at McGill University. We know from this morning's talk that Dr. Tagalakis has a special interest in cancer-associated thrombosis and does a lot of really great research, also looking at large database work. Today, Dr. Tagalakis will talk to us about anticoagulation for hospitalized patients with COVID-19.
Take this off. Thank you very much. So indeed, I do have an interest in cancer-associated thrombosis, and I often wonder how I ended up becoming having this interest as well in COVID-19 and thrombosis. And I think many of us in this room early on realized the impact and the impactful association between thrombosis and COVID-19 infection. Many of us were called upon to provide guidance as to how to best manage these patients. And certainly I found myself working on COVID wards, taking care as a hospitalist these patients early on. And it was actually very sobering to see the fact that we didn't have much to offer at that point in time and where we've come to now. So it's actually a pleasure to walk through some of the studies that have been with you to report on some of these studies that have come to fruition. So here are my relationships with commercial interests, and I'll leave that a moment for you to note. Finally, I want to highlight that I am eligible for an honorarium from Thrombosis Canada based on today's presentation. And this is how Thrombosis Canada is mitigating potential biases. So the learning objectives for this talk, 30-minute or so talk, is to review and discuss the latest anticoagulation trials in COVID-19, and then to determine how to manage anticoagulation in hospitalized patients with COVID-19 effectively and safely. I would think that most of you do have a practice based in part in hospitals, so hopefully this is quite useful to you. And some of you who work more in an outpatient basis, we may touch upon this at the end as to what to do in ambulatory patients that are affected by COVID-19. So early on, there was clearly 3 lines of evidence in support of an association between thrombosis and COVID-19 infection. There was evidence of coagulation marker changes that were noted in patients affected by COVID-19, primarily a marked D-dimer elevation that correlated with inflammatory markers, increase in fibrinogen levels, and some derangements in platelets. Autopsy studies of patients that were affected by COVID-19 and died showed microthrombi in the lungs, and the term pulmonary intravascular coagulopathy or endotheliitis was coined. And finally, there were observational studies showing that there were higher rates of thrombotic complications despite thromboprophylaxis in these patients. And at first, we had single center or even single country studies that reported on the incidence of venous thromboembolism in these patients. And finally, as a result, more and more studies were published, and we ended up having systematic reviews and meta-analysis that reported on summative rates of thrombosis. And we see this systematic review and meta-analysis by Jimenez and colleagues that looked at the totality of over 18,000 patients from among 48 studies, reporting an overall VTE incidence of 17% in hospitalized patients. And this is despite thromboprophylaxis, and obviously quite a higher rate than what we are normally used to pre-COVID time in hospitalized patients, with rates anywhere between 1 to 3%. And when they looked at in this meta-analysis, looking at factors that could have an effect on this incidence, we note that the type of assessment for VT is important, with the rates being higher if there are screening imaging done in their patient population. The rates seem to be higher if the patient's admitted in the ICU, critically ill versus the ward. And moreover, if you exclude more of the sort of quote unquote less malignant type of thrombi, such as isolated caffeine DVTs, patients with catheter-associated thrombosis, or patients with isolated subsegmental PE, the rate also seems to be lower. But this particularity to the ICU patient population, and when they looked at a subgroup analysis or meta-analysis of patients that looked at ICU patients, we see clearly here that the thrombotic incidence is much higher than that overall 17% that I just reported to you, and closer to 30% in patients who were admitted to the ICU. And when we look further on, there's another meta-analysis that showed similar with an ICU rate, with a VTE rate in ICU patient population of around 31%, compared to 5% in the non-ICU patient population. Nonetheless, both rates are higher than the traditional rates that we're used to in hospitalized patients. And moreover, when looking at the ICU patient population, we see that the thrombotic event occurrence in an ICU patient with affected COVID-19 confers a higher risk of mortality, with a thrombosis increasing the odds of mortality by as high as 74%. So why are VTE rates in hospitalized COVID-19 patients high despite standard thromboprophylaxis? Can there be different mechanisms for thrombosis explaining these higher rates than we're used to, or the commonly known pathophysiologic mechanisms that we're aware of? Or could there be inadequate dosing of low molecular weight heparins to explain these higher rates? Well, we do know, that VTE has many common risk factors for PE and DVT that are listed here and are well known to the audience. But I've highlighted here in the red box those that are potentially related to a COVID-19 infected individual who is admitted to hospital, the fact that they're hospitalized and immobilized, the fact that they have an inflammatory condition, and we know now how severely inflammatory this infection is, and obviously all mitigating their effect through the various components of Virchow's triad. But there is this feeling that there is this data, and as I alluded to earlier, that if we drill down to what is happening in the lungs of these patients, we do see that the intense inflammation that occurs as a result of infection of the COVID-19 vector induces really quite a cascade, not only a significant inflammatory cascade, but as well that implicates itself on the coagulation cascade. And so we see an activation of the vascular endothelium, resulting in platelet and leukocyte activation. And within the alveolar space, we then see dysregulated thrombin generation that also is not just specific to the lungs, but also can be seen in the systemic vasculature, inhibition of fibrinolysis, and impaired endogenous anticoagulant activity. And all this leads to fibrin disposition, resulting in tissue damage and microangiopathy. And so we can see that infection of COVID-19 on a continuum where the virus infects the pulmonary alveoli and associated vasculature, inducing changes to that endothelium, causing the inflammatory process in the alveoli, affecting the pulmonary vasculature, and then of course also having an associated effect on the systemic vasculature. And we as clinicians at the end of all this see these macrothrombotic complications. So the major questions really, or clinical questions of relevance that arose as a result of these observations was, can we improve anticoagulant thromboprophylaxis in COVID-19 patients? Can we leverage the known anti-inflammatory properties of heparins to not only have an impact on the thromboinflammation occurring in the alveolar space, but also then to decrease the rate of venous thromboembolism and also stroke and MI that was being reported in these patients, and ultimately have an impact on mortality. Moreover, there was this preliminary information suggesting that heparin may induce conformational changes in the SARS-CoV-2 receptor spike protein, thereby decreasing cellular invasion into the pulmonary epithelium and vascular endothelium. Next question was, should the dose of anticoagulant be based on COVID-19 disease severity? And some of the baseline characteristics that I mentioned earlier, such as in versus outpatient, ICU versus non-ICU, were really relevant and questions that were being asked very early on. Should D-dimers be used to guide dosing? What is the risk of bleeding in these patients? And how can we really figure this out quite rapidly, given the widespread, obviously the pandemic was significantly impacting worldwide our patients. And so the initial trials that were proposed and are still ongoing are several. And as you see here, I've separated them out according to setting, vis-a-vis pre-hospital or ambulatory patients, hospitalized patients, and post-discharge patients. The number of trials that are currently ongoing or registered, you can see, are quite vast, at least 11 studies in the pre-hospital COVID phase. Up to 33 ICU clinical trials have been reported to be ongoing in ICU, and another 50 in the non-ICU setting, and at least 2 studies that have been registered for post-COVID patients who are discharged. And different modalities of therapies are used and have been registered, as you can see there. And today I will focus on the published studies that have been reported, both for the ICU setting with Inspiration, the multi-platform randomized clinical trial studies, a study by Perepu and colleagues, an action study, and the HEP-COVID study, and as well as RAPID. I will not be discussing the HEP-COVID study, as this was sort of brought up as a phase 2 study of only 20 patients, and really out of the context of what I want to be able to concentrate on today. So the first study to report in the ICU was the Inspiration trial, and this looked at intermediate dose anticoagulation, whether or not it was better than standard dose in patients hospitalized with severe COVID-19 disease in the ICU. And this was an RCT open label. It also had a statin arm, so it had a 2x2 design that looked at whether statin had an impact. And it was done in 10 centers in Iran relatively quickly between July 2020 and November 2020. 562 patients were enrolled in this study, and it looked at an intermediate dose of enoxaparin for the duration of hospitalization, death, or 30 days. And the control arm was enoxaparin, either 40 milligrams once a day or 40 twice a day, depending on weight. And the outcome here was a composite of adjudicated VTE, arterial thrombi, ECMO, or all-cause mortality up to 30 days. And these investigators showed that there was no difference between intermediate and standard dose anticoagulation in regard to this composite outcome when dealing with ICU patients. So this was a study that sort of started the ball rolling at considering the non-effect of intermediate dose anticoagulation. Next study was Perepu and colleagues. They also looked at intermediate dose anticoagulation and whether or not this was better than standard dose in patients hospitalized with severe COVID-19 disease. Again, a randomized clinical trial, phase 3 open label. This was done primarily in the US in 3 centers between April 2020 and January 2021. Less patients in this study, 173 patients were hospitalized and admitted to the ICU and or had a modified ISTH overt DIC score. Nonetheless, around 62, more than half of the patients were ICU patients. Again, an intermediate dose was looked at until discharge 30 days or a clinical event occurred. And the comparator arm was 40 milligrams once a day of enoxaparin versus 30 twice a day, depending on weight. And this outcome was looking at all-cause mortality. Again, here we saw no difference between intermediate and standard dose regarding all-cause mortality. And so now we had a second study looking at ICU patients and looking at the intermediate dosing of a low molecular weight heparin, showing no effect on the outcome. We now go to the multi-platform RCT study, which was a collaboration between 3 publicly funded trial platforms, ATTACC, REMAP, and Active4A. As you can see bolded there, ATTACC was primarily administered out of Canada, the REMAP-CAP study out of the UK, and the Active4A out of the US. These 3 platforms came together rapidly to address a pandemic, an urgent issue going on worldwide, and it was felt resource pooling and coming together to answer this question and being able to be quite flexible and pivot as a result of the urgency required was extremely a phenomenal thing. And so as a result, we do have data that came out quickly as with these three platforms coming together. So in the New England Journal, the study was reported, both studies divided according to the setting. So at the top, you see the critically ill patient a manuscript, and at the bottom, the patients in the non-critical or moderately ill was reported. So the question here is, will therapeutic, so now we're looking at a therapeutic dose of anticoagulation with low molecular weight heparin. Can this improve in-hospital survival and decrease the need for organ support in critically ill COVID-19 affected patients? Again, an RCT open label. Here we had a lot more patients as a result of this pooling of resources across these platforms. So 1,098 COVID positive patients who were critically ill, requiring organ support or ICU level care from 9 different countries between April 2020 and December 2020 participated in this study. And I do believe that several members in this audience today were site investigators on this study and have had that experience of really seeing on the ground how this study worked. Once again, therapeutic dose low molecular weight heparin was used for up to 14 days or until recovery, and defined as either a hospital discharge or discontinuation of supplemental oxygen for at least 24 hours. Usual care was a little bit different in this study. The control arm, was a little bit different in the study, as they allowed for usual care according to whatever the site was doing. I can tell you, for example, many sites with the publication of studies out of China and Europe early on showing a higher risk of thrombosis were adopting an intermediate dose for their thromboprophylaxis in these patients. And hence you see that in this arm of control in the ATTACC study, 60% of patients were receiving intermediate or higher dose, and 40% were receiving standard dose. The outcome was survival to 21 days and organ support free days. And by organ support free days, we mean high flow oxygen. The support measures are high flow oxygen, mechanical ventilation with or without intubation, and vasopressor or inotrope support. So particular again to this study was an ordinal scale was used as a composite of in-hospital mortality and organ-free support days until the end of study day 21, where death was the worst outcome possible, counting as -1. And so here we see the table that reports on the critical ill group. So those patients requiring ICU or ICU level care. And again, we note that there was no benefit conferred by therapeutic anticoagulation compared to standard care. And in fact, potentially there was a higher signal or a signal for a higher risk of bleeding in this patient population. With when we look down at the major bleeding, 3.8% of patients in the therapeutic arm experienced a major bleed versus 2.3% in the usual care. When we look at the non-critically ill, so perhaps a group of patients that some of you are more inclined to probably be treating or managing in your hospital centers, we also had the same question as to whether therapeutic dose anticoagulation improves survival and decrease the need for organ support in moderately ill patients. So patients not receiving ICU level care. Again, an RCT open label, and we had 2,219 patients enrolled across 129 global sites from April 2020 to January 2021. Quite a dramatic and important feat. And so again, these were patients without the need for ICU level care. And they were stratified initially between high, lower, unknown D-dimer. The intervention here was therapeutic dose low molecular weight heparin for up to 14 days or until recovery. And again, similar to the ICU study, the control arm include usual care, and this was defined differently in different centers, but it did allow up to 25% of patients to have intermediate or a higher dose of what would be expected as a usual thromboprophylaxis regimen. And the outcome is similar to what I just described earlier for the ICU stratum. And here what we did see was that the probability that there was a difference between therapeutic dose anticoagulation versus usual care thromboprophylaxis in favor of therapeutic dose anticoagulation was 98.6%. And the difference was a statistically significant 4% difference, that therapeutic dose heparin improved the probability of survival to hospital discharge with fewer days of organ support compared to usual care thromboprophylaxis, and this was done without an increased risk in major bleeding. And so this is a summative of the two studies together, where the authors were concluded that therapeutic anticoagulation improved probability of surviving to hospital discharge with fewer days of organ support in patients with COVID-19 infection who are moderately ill without an excess in bleeding, but not in patients with severe infection. Then we move on to the ACTION trial. Again, the ACTION trial is in the setting of a hospital setting of moderately ill patients, not ICU level patients. But a particularity here is that a direct oral anticoagulant was used as the therapeutic intervention. And so perhaps different than what we would be thinking about leveraging those anti-inflammatory effects of a heparin-based regimen. And what's also interesting is that we are also looking at an outpatient extending prophylaxis past discharge and up to 30 days. So the question here was, will therapeutic dose anticoagulation improve survival, duration of hospitalization, or duration of oxygen use in non-critically ill COVID-19 infected patients? They enrolled 615 COVID patients with high D-dimer levels. And this was a study done entirely in Brazil at 31 sites, again, relatively quickly between June 2020 and February 2021. And the intervention here, the DOAC that was used was rivaroxaban 20 milligrams once a day for 30 days, irrespective of hospital discharge status or not. They did allow for initial therapeutic dose unfractionated heparin or enoxaparin in patients that were deemed unstable. In-hospital prophylactic dose enoxaparin or unfractionated heparin was the comparator, and extended prophylaxis was allowed, and this was a patient by patient and at the MD's treating physician's discretion. This occurred in about 13% of patients. The outcome again was a hierarchical composite of time to death, duration of hospitalization, or duration of oxygen through 30 days. And the ACTION trial did not show any benefit, and in fact showed excess bleeding with rivaroxaban for 30 days. And as you can see there, the excess bleeding was a significant finding, with 8% of patients in the therapeutic anticoagulation group experiencing a major bleed versus 2% in the prophylactic anticoagulation group. So something different being seen with a direct oral anticoagulant, and moreover, different than the other studies that were now proposed to extend past discharge, and perhaps these patients are not so much at risk of thrombosis at that point in time. And the tipping point here is that they would experience excess bleeding if we did anticoagulate them. We'll move on. Fresh, recently published the HEP-COVID trial, and they too looked at hospitalized patients, moderately ill, therapeutic dose anticoagulation. They looked at 253 COVID. They enrolled 253 patients. There was an ICU stratum in the study. About 1/3 of patients were enrolled in the were from the ICU, and they looked at enoxaparin therapeutic dosing, as noted there, for the duration of hospitalization, day 30, death, or patient withdrawal. And the control was prophylactic or intermediate dose heparin or enoxaparin. And you can see here that almost 61% were on prophylactic dose. And as I mentioned earlier, intermediate use was allowed in this control arm. And the composite here was VTE, ATE, or death at 30 days. And what we did see here highlighted in green was that there was a benefit to therapeutic dose heparin. It did improve the risk of thrombosis and survival to hospital discharge. So you can see here that in the therapeutic arm, VTE, AT, or death occurred in 28.7% of patients versus 41.9% in the standard dose. So there was a significant improvement by using therapeutic dose heparins, and this was primarily seen in the non-ICU stratum and not the ICU stratum. So again, something seems to be showing a benefit in our moderately ill patients, but not so much in the ICU patients. And when we look at major bleeding, there didn't seem to be any difference in the non-ICU stratum for bleeding, although in the ICU stratum, we see that there were 4 bleeds compared to 0 in the standard dose. And looking at, I had forgotten to mention at the beginning, there was a screening done at 14 days in this of lower limbs with a Doppler ultrasound in all of these patients that were enrolled in this study. So one would wonder, are we picking up incidental DVTs or asymptomatic DVTs in these patients? And in fact, the pickup was quite low. When you look at asymptomatic proximal DVT, the rate was 1.6 in the therapeutic dose versus 2.4 in the standard dose. So most of these were clinically evident thrombotic complications. The last trial that I'll talk about is the RAPID trial. And for those of you who were attending yesterday's CanVector meeting, you heard Dr. Schulzberg discuss the RAPID trial. She's the co-PI of that study. That study looked at, and some of you probably may have in the room here participated in this study. It looked at therapeutic dose anticoagulation and whether it improves survival, need for mechanical ventilation, or ICU admission in hospitalized patients with COVID-19. Again, 465 patients were randomized to therapeutic heparin versus prophylactic dose, sorry, there was a typo there, therapeutic heparin for the duration of hospitalization up to day 28, death or patient withdrawal. And the control was a mixture of, prophylactic heparin. It was put in the protocol that intermediate dosing would not be eligible to be included in the study. So there was a cap of the prophylactic dosing. So once again, these were hospitalized patients and all with elevated D-dimers, and enrollment occurred between May 2020 and April 2021, and from various countries, primarily Brazil, Canada, and some patients from Saudi Arabia, Ireland, USA, and the United Arab Emirates. And the outcome was ICU admission, mechanical ventilation, or death up to 28 days. And what we saw here in the primary outcome was that there was no difference when looking at the primary composite outcome. It occurred in 16.2%. There's no statistically significant difference, meaning that it occurred in 16.2% in the therapeutic arm versus 21.9% in the prophylactic arm. The odds were 0.69 in favor of therapeutic anticoagulation, but obviously the 95% confidence interval, as noted there, did cross unity. What was interesting though, and I'm not sure why the triangle, the box, but if you look right below the secondary outcome, looking at death and death from any cause, there was a statistically significant difference between the occurrence of death between these two arms. In the therapeutic arm, this occurred in 1.8% of patients versus 7.6% in the prophylactic arm, for an odds of 0.22 and a confidence interval that does not cross unity. Apologies that that box may be blurring that outcome there. And what's interesting to note is that major bleeding occurred in 0.9% of the therapeutic arm, but 1.7% of the prophylactic arm. Again, a very interesting kind of counterintuitive finding that prophylactic anticoagulation seemed to confer perhaps by absolute numbers a higher risk. And one would wonder if this is a chance occurrence. So if I had to summarize in this table, and this is probably my third to last slide, I've sort of put all the studies in this table, and starting with the COVID patient population, you can see early on that the ICU patient population focus studies primarily looked at intermediate dose versus prophylactic, and that really did not show any difference between the two arms. We have the ICU stratum from the platform trial, all comparing therapeutic versus prophylactic or intermediate. And there the suggestion was that perhaps prophylactic is better and safer. When we look at all the studies that looked at moderately ill patients, both from the ATTACC study, ACTION, HEP-COVID, and RAPID, we do note that therapeutic dose probably confers an advantage in these patients in the various outcomes. But what's certain is that the only study looking at direct oral anticoagulant does not seem to show that either. So why we're seeing that this sort of difference between the course of the disease vis-a-vis COVID-19 infection and the impact of our antithrombotics may be that there is some sort of point or tipping point where the disease is gone too far, that cascade of the thromboinflammation is difficult to break with anticoagulation. And perhaps that's why we're not seeing a benefit in our severely ill ICU level type care, patients that are receiving ICU level type care. And probably starting earlier our anticoagulant before they become critically ill makes a difference for these patients. I haven't, discussed the starting early, but probably not starting too early, because we did have data recently reported from the ACTIV-4A investigators. And in fact, they had to stop that study early. That study looked at outpatients with COVID-19 infection, randomizing patients to aspirin, a DOAC, a PIXA-5, or the other arm being a PIXA 2.5 twice a day, versus placebo, and the rates were very, very low for thrombotic complications, so that the study had to be stopped early. So there may be importance at how we time our antithrombotics here. So in conclusion, therapeutic low molecular weight heparin is associated with improved outcomes in hospitalized patients with COVID-19 infection who are not critically ill or in an ICU setting. And I would have to say particularly, even though we didn't see a difference in the ATTACC study when they looked at their sub-analysis vis-a-vis D-dimer stratification, all these patients, other studies included patients with high D-dimer levels. So there probably is the selection of these types of patients benefiting. Number two, patients who are critically ill or in ICU do not benefit from therapeutic anticoagulation and may have an increased risk of bleeding. Thirdly, the benefit of therapeutic anticoagulation may not extend to other classes of anticoagulants, as noted by the ACTION trial. And I do believe that intermediate dose anticoagulation has no therapeutic utility in these patients. And that's it. Thank you very much.
Thank you so much, Dr. Tagalakis. That was a really thorough overview and nicely summarized the findings of these pivotal trials. There is a lot of information, as you mentioned, that's still anticipated with a number of trials that are continuing. Tell us what you've done in your institution and how you are treating patients in the hospital wards, so non-ICU population.
So we actually pivoted very early on in the pandemic. So as you know, we had the advantage of being a hospital center that was involved in one of these studies, the ATTACC study. And so we were quite aware about the inclusion and exclusion criteria. And clearly all these studies have an extensive list of exclusion criteria, meaning that risk of bleeding needs to be determined, and only patients deemed to be at low risk of bleeding were entered into this study. So early on, as the preliminary results of ATTACC came out, we quickly pivoted and modified our anticoagulation protocols for moderately ill patients and advocated for therapeutic dose anticoagulation, particularly low molecular weight heparin, with using criteria or exclusion criteria defined in our protocol. So for example, patients with advanced renal disease were not included. Patients with significant thrombocytopenia would not have, for example, be upped to a therapeutic dose anticoagulation. We also were very cognizant of the fact that although pregnant women were not included in these trials, we felt that it was morally, not right to at least offer therapeutic anticoagulation as well to these women. And so we did include pregnant women in our protocol and accessing therapeutic anticoagulation for them. We involved a multidisciplinary approach to these women where there would be a consult, for example, with our thrombosis specialist and our OBGYN specialist. So that's what we have done. We did not endorse therapeutic anticoagulation in our ICUs, and in fact, did a lot of on-the-ground work and continue to do with some of our ICU folks about not using intermediate dose anticoagulation in these patients.
I think Dr. Tagalakis, do you have a question?
Yeah.
Yeah, thank you very much, Vicky. That was really an outstanding summation of the data. And just to follow up on your point about what your practice was, I think we all know that the practice worldwide is quite variable. I mean, I think if you talk to colleagues in certain European countries, they haven't really embraced the use of anticoagulation. And I know that in January, when the multi-platform trials came out, I mean, even at our own institution, among myself and other general internists, there was a lot of pushback about adapting therapeutic anticoagulation. And I wonder, why that is, and, so just your general view on that. And my specific question is that, when we started off in the pandemic, somebody came in with COVID, we just gave them oxygen. Yeah. And now they're on Dex, they're on remdesivir, they're on Tosy, and maybe on an anticoagulant. So, I wonder whether if we can possibly tease out those patients who are receiving optimal anti-inflammatory and antiviral therapy and see what is the additive benefit, if any, of therapeutic anticoagulation, if we're postulating that its benefits are mediated through as much as through inflammatory as through anticoagulant mechanisms. So just your thoughts about these things.
I totally agree with you. And in fact, I haven't presented this data, but in reviewing the literature and reviewing these studies, I carefully looked at those baseline characteristics in these patients and looking to see what kind of, how many of these patients were on steroids. So you'd be surprised, Jim, that in fact, I would say in all the studies, the percentage of baseline use of corticosteroids. And so obviously I don't know the dosing because the dosing has changed over time as well. And dosing changes according to whether you're on the medical ward or in the ICU vis-a-vis steroids. But I would say that 85% on average reported in these studies were on steroids. Not the same though regarding the antiretrovirals that you mentioned earlier, but it was at least comforting to me to see that some of the more anti-inflammatory targets that we're using pervasively in these patients were commonly used in these studies. But you're right, care will change, new therapeutics will come, and anticoagulants therapeutic dose, in my mind, are quote unquote, we make lists in our hospital, and I'm part of the PT committee, and we labeled drugs as dangerous or not, and therapeutics anticoagulant is in that category, given that the risk of bleeding. And obviously, when you look, and Dr. Castellucci asked me what we do in our institution, and one would think you have a protocol that would be, quite simple, but our protocol for these patients is like a 2-pager. Because we realize bleeding is an issue and it may not be easily picked up in a trial. As you know, the side effects take larger patient populations and over time to see the side effects. And so we put in these contingencies for the different types of patients that according to risk of bleeding. And so certainly over time, I wouldn't be surprised in a year or 2 years that we're re-looking at this data and saying, look, we have better therapeutics now with less of a downside, and how much is therapeutic anticoagulation adding here? So today, November 2021, if I were coming in with COVID-19, I would be asking, to be hospitalized, to be put on therapeutic anticoagulation, knowing my risks of bleeding are very low. Will it be the same in a year from now when we're doing this, conference again and talking about COVID-19? Then I don't know. But at least, I acknowledge that question. And when I look, like I said, in these questions and the profiles, you do see that a quite substantial amount of these patients were on steroids, at least.
Thank you so much for that,
Yeah.
Dr. Tagalakis. It's been a great talk, generating lots of questions.